So my name is J.W. Snider, and good morning. I come from the UAB Proton Center in Birmingham, Alabama. I'm an associate professor and associate medical director of proton therapy here. I'm going to be speaking to you today about proton therapy, a fairly somewhat new but fairly established therapy for the pediatric population in particular that holds a lot of promise in both increasing disease control rates for some patients as well as reducing side effects. I do have some disclosures to report, mostly related to industry sponsorship that I hold, as well as that this speech in particular, I am receiving an honorarium from Varian Medical Systems, which is the company that develops our device. So a little bit about our center here at UAB. The center at UAB is a partnership between Proton International, which is a for-profit institution, and the UAB, or University of Alabama at Birmingham Radiation Oncology Department, who provides all of the clinical services within our building. It's owned and operated by Proton International. It's a $90 million investment, 32,000 square foot facility. It is the second single vault gantry center in the United States, and it does house a Varian ProBeam proton therapy system. It is located on the campus of the University of Alabama at Birmingham. It does have a small clinic with 6 exam rooms and 1 anesthesia suite for induction and recovery, especially of our pediatric patients, which we'll be talking about here in a minute. And then it did treat its first patient. We treated our first patient here in March of this year. So we've been operational for a little over 7 months now. But we are excited to bring this technology, which is established in the United States and an established device and system that we utilize here, but bring it to the state of Alabama as the only proton therapy center in the state, and also a resource to the surrounding communities. So Mississippi, for example, does not have a proton therapy center, so we see a lot of patients from the surrounding areas and states. Proton therapy is not a new idea. Certainly it was first suggested in 1946 by Robert Wilson as possibly utilizing protons for the treatment of patients with malignancies because of the unique characteristics of the Bragg peak effect that we see with proton therapy, meaning that it has a limited range. It has almost no exit dose and really a low entrance dose, which can make our dose of radiotherapy more conformal to our target and reduce exposure to normal tissues in a patient's body. It is particularly beneficial in the pediatric population, which we are going to be speaking about today. So why are protons different than photons or X-ray treatments? Well, as you can see from this graph, if we're trying to treat a tumor in the shaded area in the middle of the slide, then we really want to keep the dose there as much as possible. With an X-ray beam, which you can see in the pink, unfortunately, the dose goes through and through, in one side of the body and out the other. So I liken it when we speak to patients about shooting a bullet straight through the tumor. It goes in one side and out the other, or like hundreds of flashlights sort of shined at the center of a circle. At the center of the circle will be very bright, but the surrounding areas will have lower and moderate areas of light that are, quote unquote, unnecessary. Unfortunately, those lower and moderate areas of light spread out into the normal tissues of the patient, which can be particularly damaging to a young patient who has developing tissues like a pediatric patient. Instead, proton beams are delivered with the Bragg peak effect, where they have a limited range. They peak at the end of their range, delivering most of their dose near the end of their range. So we stack these Bragg peaks to create what's called the spread out Bragg peak region, or the SOBP. That reduces certainly exit dose, because we have almost no exit dose, whereas photons certainly have a substantial amount of them, and can reduce entrance dose depending upon the depth of the tumor and where it's located. So essentially, protons are different because they stop within the body and therefore have virtually no exit dose, whereas photons or X-rays pass straight through. Protons can reduce some of the unnecessary dose to surrounding organs and organs at risk. And also that gives us the ability to do one of two things in each patient. Either we can escalate the dose to the tumor and do that safely while preventing damage to the surrounding critical tissues, or we can decrease dose to surrounding critical organs and therefore reduce the morbidity of our therapy. Both can be important in the pediatric population, but especially the latter of reducing dose to normal critical tissues is, of course, of particular benefit in the young patient population who have developing normal tissues. So this next slide shows the sort of the quintessential picture of proton therapy versus X-rays. And it is apt for this discussion because it is something we commonly do in the pediatric population, which is craniospinal irradiation. Unfortunately, tumors like medulloblastoma require us to radiate when necessary. the entire craniospinal axis, meaning the brain and entire spinal cord and thecal sac. That means a long length of the patient is exposed to radiotherapy, as well as a lot of normal tissues all up and down the patient's body. So the morbidity can be significant, and it can affect a lot of different tissues throughout a patient's body. As you can see on the left, this is a quintessential or traditional X-ray technique. This is a 3D technique where we would treat mostly from the back for the spine and laterals for the head for the brain. You can see that unfortunately that has a lot of exit dose going into the patient's heart, lungs, liver, bowels, gonadal tissues at the bottom, some of their anterior head and neck region. A lot of normal tissues that are not part of our target in the craniospinal axis, but unfortunately based on the properties, physical properties of X-rays as they traverse the human body, those tissues are exposed. Whereas in proton therapy on the right, you can see that we go into a certain depth and stop within the body. So particularly for treating the spinal region, you can see that the dose is really limited to where we want it in the craniospinal axis, therefore reducing almost to no dose in the heart, lungs, bowels, anterior structures, gonadal tissues, things that are very critical for the rest of this patient's life, especially as outcomes become better in the pediatric population. And as many of these patients are surviving this radiotherapy, we get to see the long-term effects of our therapy, unfortunately. And so reducing that is of utmost importance in this population. The next slide shows a video. I'm going to go ahead and hit play on it. But basically, this is an animation of what happens inside of our treatment room. Our gantry is actually 300 tons of weight, and it actually spans 3 stories from the top of the building to the bottom, above and below the patient. But what the patient experiences is what you're seeing here. They lie on a robotic couch that has 6 degrees of freedom. It can in, out, up, down, left, right, roll, pitch, and yaw within about 1 millimeter of accuracy and a degree of accuracy. It can take a cone beam CT, which is what you're seeing in this animation at the moment, taking a 3-dimensional image of the patient while they're lying on the table to make sure that they and their tumor are as properly aligned as possible. And then we go to delivery. And in our system, we use pencil beam scanning proton therapy. So we use a tiny, about 7 to 8 millimeter across pencil beam to draw the dose within inside the patient's body, almost like a 3D printer, printing the dose inside the patient's body to be as conformal as we possibly can be to the target within the patient. And so really this is about as conformal as we can get with radiotherapy these days, with proton therapy in the United States available at about 30 institutions, as well as internationally available at many institutions in different countries around the world. But this is the newest, latest, and greatest version of it in pencil beam scanning, and it allows us to be as protective of normal tissues while as ablative to tumoral tissue as possible within a patient's body. And you can see how we paint the dose almost layer by layer by doing energy switches or reducing the energy of the proton beam layer by layer until we've painted the entirety of our target. So I want to talk a little bit about particularly how this tool is utilized in the pediatric population. That's the point of today's talk. And really, I want to talk about why and how it has established its role within the pediatric oncology sort of organization or community. So pencil beam scanning proton therapy in particular has given us really the ability to treat all over the body. And it's allowed us to use proton therapy in whatever disease sites a patient may have it in, a tumor in, but to protect more normal tissue and be as conformal to the patient's body as possible, use as many beams as we need to utilize as possible. And it makes it appropriate for many different disease sites all over the body. However, of course, as proton therapy came out in its advent, the CNS was an easy target for it, and certainly has the longest track history in treating CNS malignancies, especially in the brain and spine. It makes it a natural pairing in the pediatric population, since so many tumors in the pediatric population are within the CNS. It does have the potential to reduce both short-term, subacute, and long-term toxicity associated with radiation therapy. And so that was something of focus, of course, in the pediatric population. And young patients with a good prognosis, we really have to worry about their long-term toxicity in particular. And it has become somewhat of a preferred modality when a patient can logistically and technically receive proton therapy for their malignancy. Proton therapy centers continue to proliferate around the world and around the country in the United States. That makes it more available to patients, and payers, especially with insurance companies, for example, in the United States, have become more willing to pay for this technology, especially for the pediatric population. Still, it's all about proper patient selection, and that's key. And there's proper techniques that are crucial to delivering especially pencil beam scanning proton therapy to patients. So let's talk about CNS tumors in particular. With improvements in chemotherapeutic, neurosurgical, and radiation techniques, really survival has substantially improved, especially for CNS tumors in the pediatric population. Over the last several decades, it's gone from about half of patients surviving to over 3/4 of patients surviving. And so now as prognosis improves, toxicity comes more into focus, especially long-term toxicity. And unfortunately, radiotherapy and brain tumors can cause significant neurocognitive deficits, endocrine deficiencies, attention, intelligence, and processing deficits, psychosocial functioning issues, as well as hearing deficits. So all of these, amongst other toxicities that we can see in the CNS, are important and critical, especially to the long-term prognosis from a morbidity standpoint for the pediatric population. And certainly this population is in focus for this technology. The next slide shows an example plan for a glioma treatment. This is a simultaneous integrated boost technique. So you're seeing a lower dose going to this blue volume and a higher dose going to the green volume. But in essence, what you're seeing from left to right is a progression of conformality of radiation dose from old school techniques to newer techniques. So on the far left, you'll see a 3D radiation technique, which is not necessarily that old school, still something we utilize in the clinic in the right clinical scenario. Next, you see a step and shoot IMRT, or sort of an older version of IMRT technique. The third one is VMAT, or volumetric modulated arc therapy, sort of the most conformal of IMRT techniques. And you can see how tight it does make the high and low dose, the high and moderate doses to the target here, but unfortunately some of the low, moderate, and low doses spread out to the rest of the patient in the purples and blues there. And then on the far right, you can see pencil beam scanning proton therapy, which makes us as conformal as possible to the patient's target or the tumor within the patient, as well as reducing dose to the contralateral structures, the anterior structures, and a lot of the uninvolved brain and brain tissue. And so you can see on the far right what we would do in our clinic with pencil beam scanning proton therapy and how sparing this can be to a patient's normal tissues, especially in brain tissue, which is of particular concern in the pediatric population. On the bottom, you can see sort of sagittal slices of this. And again, you can see the spread out of low and moderate doses to the rest of the brain in the IMRT and 3D techniques, whereas we really keep the dose as conformal as possible and really within the tumoral area and tumoral bed in this patient on the far right. The next slide actually shows a complex target in whole ventricular irradiation within the CNS, another common technique in the pediatric population. Again, even with a complex target, even with complex shape and a deep-seated positioning, proton therapy can be highly conformal and really reduce dose to surrounding brain tissue and normal tissues within the patient. So again, another benefit for these patients. Craniospinal irradiation, as we discuss on the next slide, is actually one of the more common techniques in the pediatric population because of CNS tumors that can seed throughout the CNS. And so craniospinal irradiation, unfortunately, becomes very common in this population and can have pretty severe side effects, both short and long term for the patient. Proton therapy in the boost phase can reduce maybe neurocognitive, endocrine, and auditory sequelae by reducing the boost phase to just sort of the posterior fossa or wherever the tumor was seated. However, its more vast reductions happen in the CSI portion of the treatment, where we see the integral low and moderate doses to structures anterior to the spine, especially, to be vastly reduced from fairly significant to almost zero in patients receiving proton therapy. That means reduced dose to the heart, lung, esophagus, anterior head neck structures, genitals, bladder, gonadal tissues, as well as reduction in hopefully secondary malignancy from integral dose spreading out to normal tissues within the patient. There's also the potential for vertebral body or marrow sparing, which may reduce the sort of marrow effects of radiotherapy and what we may see in a patient's blood work and suppression of their immune system during the course of therapy. I've already shown you one picture of craniospinal irradiation, but certainly this is the most illustrative picture of what proton therapy can do. And the initial picture was one from a book. I'm going to show you a real one. So this is a patient that was treated within our clinic. He needed to start craniospinal irradiation fairly urgently. So what you can see on the left is his initial photon plan that he started with for the first few days of therapy while we prepared a CSI proton plan, which you can see he completed therapy with on the right. And you can see the vast reductions in dose to his heart, lungs, anterior critical structures like his bladder and bowel, and gonadal tissues at the bottom. So fairly significant dose reductions to a lot of critical structures up and down this patient's body, which will have both short-term and long-term sparing for this patient to improve his outcomes. There are challenges that come with proton therapy in the pediatric population. Certainly the requirement for anesthesia, which is why we have to have an anesthesia bay in this center, and an anesthesia agreement with an anesthesia group to perform that for patients here. Uncertainties around vertebral body sparing can be, especially in young patients, about whether or not we'll see scoliosis long-term, is something that's of concern in a clinical trial question currently. And then there's radiobiologic uncertainties. So we have to hit our target. It's a little more uncertain when we do so with proton therapy, but also the radiobiologic effects of proton therapy are still being modeled accurately to give us accurate models of LET or linear energy transfer within a body. We are working on that, although we're close enough that I think it's okay to clinically treat with patients with the correction that proton therapy is about 10% more radiobiologically effective than photon therapy. However, this continues to be an area of active research and modeling. I'm going to cover two more disease sites for pediatric patients, particularly the soft tissue tumors or sarcomas. These can pop up anywhere all over the body, but especially in the parameningeal region is a common place that we end up dealing with these in the pediatric population. It maintains the potential over photon radiotherapy for reductions in morbidity all over the body. So craniofacial deformities, growth retardation, endocrine dysfunctions, peripheral nerve damages, pelvic or gonadal dysfunctions, joint or bone abnormalities, or reductions in secondary malignancies, et cetera, because of so many different disease sites being possible for soft tissue tumors in the pediatric population. There's a lot going on here and a lot that proton therapy can offer for these patients. But again, it's a case-by-case basis and a patient selection issue where your radiation oncologist will help guide you towards the right treatment for the right patient. And certainly in thoracic and abdominopelvic tumors, again, we can see these commonly in the pediatric population, whether it be lymphomas like Hodgkin's lymphoma or neuroblastomas, for example. There's strong evidence suggesting a link between radiotherapy dose to critical structures and significant severe late side effects. So one of the ones that I wanted to point out here was the cardiac effects. This is a lymphoma study that you can see here. It was published in the JCO in 2016, but basically they modeled out how much radiotherapy dose to the heart matters. And they showed that for every mean gray dose of to the heart, we increase the risk of long-term cardiac morbidity or mortality by about 7.4%. That's a pretty substantial increase, especially for these patients who will live long-term. And you can see on the right sort of a modeling of how much dose the patient received of their heart versus what their risk of cardiac morbidity or mortality was, or congestive heart disease. And so that's a fairly significant link, and we always want to reduce the dose to the heart now. And we are even more sort of motivated to do so in the pediatric population. And when we're treating the craniospinal axis, for example, with photons, we can't stop some dose from going to the heart, but with protons, we can really reduce the dose to almost zero. In lymphomas of the anterior mediastinum, that's another place where, again, proton therapy is going to become particularly essential for the pediatric population. So again, a very powerful tool for the right patients to reduce both their short and long-term morbidity. Challenges in thoracic and abdominal pelvic tumors, certainly, again, requiring anesthesia, sometimes for extended periods of time in the room, although the treatment is not much longer than a photon treatment. It can be relatively on the same measure, but it can be slightly longer. And again, challenges in the thoracic cavity, especially with interplay effect, motion management, and heterogeneity within the beam path. But I think all of these are overcomeable. It's just about being in an institution that has sort of addressed these issues and is able to deliver proton therapy to these regions of the body. And again, radiobiologic uncertainties come with proton therapy at the moment. So the last thing I want to touch on is secondary malignancies. Certainly one of the greatest and worst and most feared toxicities of radiation therapy, just like systemic agents, is secondary malignancies or causing cancer. Certainly we cure a lot of patients, and that's the reason that we utilize radiation therapy all over the body and even in the pediatric population. But we can cause malignancies with our therapy in the pediatric population because of their long-term survival, often after this treatment, may be particularly apt for formation of the secondary malignancy following radiotherapy. There have been two large studies done by the SEER database as well as the NCDB database that you can see represented in the figure below. But basically, we showed that IMRT versus 3D CRT did not show a substantial difference in in secondary malignancies, whereas proton therapy did show a substantial reduction in secondary malignancies over IMRT, both in the MGH series coming from the SEER database, as well as in the NCDB database results that we saw on a larger patient population standpoint. Again, these things need to be verified in prospective trials, but this is encouraging data suggesting that the reduction in integral dose, meaning the low and moderate dose spread out to surrounding normal tissues that we see with photon therapy that is reduced with proton therapy, may not only lead to reductions in short-term, subacute, and long-term toxicities that we have discussed, but also a reduction in secondary malignancies or reduction in the cancers we cause as a result of our therapy. So this is a very serious and grave improvement in our radiotherapy by utilizing proton therapy in this population. In summary, proton therapy has really become a preferred modality in the treatment of the pediatric population because of its reduction in short-term, subacute, and long-term toxicity, but also because of the long-term prognosis of these patients, that they're going to live the rest of their lives with the side effects that we cause from our radiotherapy. And so their tissues are particularly deserving of sparing if we can do so. And proton therapy gives us the sharpest knife, I guess, with which to cut with radiotherapy to treat a patient's malignancy adequately while reducing dose to normal tissues and critical structures in the surrounding area. I'd like to thank the organizers of the eCancer Online Congress 2020 for inviting me. I'd like to thank Varian Medical Systems for sponsoring this talk, as well as the UAB Proton Therapy Center, the team that you can see on the right here. It's a pleasure to work with them on a daily basis, and they make this possible for me. Thanks very much.